Welcome to MitoCast by Mito Foundation. We share information and resources to support people with Mito, their families, and the wider community. All content is created by Mito Foundation. AI text-to-voice technology is used only for the production to make our resources easier for everyone to access.
If you have ever caught yourself lifting your chin a little higher just to see under your own eyelids, or turning your whole head because your eyes will not quite look where you want them to, you are already close to the heart of today's topic: chronic progressive external ophthalmoplegia, or CPEO, a type of mitochondrial disease, or Mito for short, that most visibly affects the muscles around the eyes. Everything we're sharing here comes from the Mito Foundation's CPEO information page, which you can find on mito.org.au and search for CPEO.
That name sounds huge and a bit scary, honestly. CPEO, even saying it feels clinical. Can we start with what it actually means for a real person on a regular Monday, not just a definition on a page?
Yes, and that is exactly why CPEO matters to talk about in plain language. CPEO is described as a rare genetic condition, and it is one of at least 350 known types of Mito. In Mito, the tiny parts inside our cells called mitochondria do not work properly. Mitochondria help make energy in your cells, and they have other roles too. When they cannot produce the energy your body needs, different body parts, like muscles or the brain, can struggle to work the way they should.
So with CPEO, the eye muscles are the ones that run out of energy first? Is that why people notice their vision changing, even if their eyesight itself might be fine?
That is a helpful way to picture it. With CPEO, people experience weakness in their eye muscles, and that can impact vision because your eyes may not move as smoothly or as far as you need. The eye muscles are particularly sensitive because they contain many mitochondria. So when genetic changes affect mitochondrial function, the eye muscles can be hit hard.
Okay, and when you say eye muscles, you mean the muscles that move the eyeball around, not just the eyelids, right?
Exactly. One of the main features is weakness of the muscles that move the eyes, called ophthalmoplegia, which simply means the eye movement muscles are weak. In CPEO, it is the external eye movement muscles, the ones that aim the eyes up, down, side to side, and in circles. As that weakness worsens, some people find they turn their head to see in different directions because the eyes cannot easily track there on their own.
And the other big one is droopy eyelids, right? I have heard the word ptosis used, but I never knew what it meant.
Ptosis is the term for drooping upper eyelids. It can affect one eyelid or both. And it is not just cosmetic. If the lid droops far enough, it can block part of your vision. As ptosis worsens, you might use your forehead muscles to try to lift your eyelids or lift your chin to see.
That sounds so tiring. Like you are doing extra work just to look at the world.
It can be. And it helps to name that for what it is: extra effort. CPEO is described as progressive, meaning it can worsen over time. The main symptoms are that impaired eye movement, ophthalmoplegia, and droopy eyelids. Ptosis. But it is also important to know that it can present differently in different people, and it can be an isolated disorder or a multi-system disorder.
That phrase, multi-system, is the part that makes me pause. Does that mean CPEO is not only about eyes?
That is an important point, and we will come back to it in a myth and fact moment later, because it is a common misunderstanding. For now, let's stay with what someone might notice. Beyond the eye symptoms, there are others that can happen for some people. One is muscle weakness, called myopathy, which means general weakness of the muscles used for movement, often noticed in the neck, arms, or legs.
So myopathy is like muscle weakness in general, but exercise intolerance is also mentioned. Is that just feeling unfit or something different?
Exercise intolerance is explained as a reduced ability to do physical activity at a level typical for someone's age and size. Some examples are getting tired more quickly than expected, feeling out of breath, weak, or even nauseous. It is not a moral failing. It is not lack of effort. It is a body saying, my energy systems are not meeting this demand.
That is such a relief to hear said out loud because people can internalize it. They think, I should be able to keep up.
And that can be a heavy emotional load on top of the physical one. Another symptom is difficulty swallowing, called dysphagia. Dysphagia means swallowing is difficult because the muscles and nerves that help you swallow are not working properly. It can feel like food is getting stuck, or you might experience choking episodes.
That is the kind of symptom that can feel alarming, especially if you do not know it can be connected. Does the page talk about other symptoms too?
It does. It lists other possible signs and symptoms, including hearing loss from nerve damage in the inner ear, called sensorineural hearing loss, and weakness or loss of feeling in the limbs from nerve damage, called neuropathy. It also mentions impaired muscle coordination, called ataxia, a movement disorder called Parkinsonism, and depression.
That is a wide range, and it makes me think about how confusing it can be to connect the dots, especially if the first thing you notice is something like droopy eyelids.
Yes. When these additional signs and symptoms are diagnosed alongside the eye features, the condition can be called CPEO+. That naming matters because it acknowledges the plus symptoms, and it can help guide monitoring and care.
Before we go further, can we talk about when symptoms usually begin? Because I have heard CPEO described as adult onset, but then you also said it can start at any age.
It usually starts in early adulthood, around 20, but can start at any age. It also notes that symptoms can be more severe the earlier they start, and that CPEO is progressive and can worsen over time. That does not tell any one person's story. It just gives a broad pattern that can help people make sense of what they are seeing.
And how common is it? Rare can mean a lot of things.
CPEO, it rare, but also says it is one of the most common types of mito and the most common type of mitochondrial myopathy. It also says the exact number of people worldwide with CPEO is not known, but gives an estimate that it occurs in about 1 to 2 out of every 100,000 people. And that in the United Kingdom, records show about 1 in 30,000 people have CPEO.
Hearing numbers can be strange because it can feel both isolating and also, in a way, reassuring. Like, okay, I am not alone, but I might not know anyone down the street with this.
That is why connection matters so much in the Mito community. And one thing the page does well is bring in a real person's experience. It introduces Emmy, who noticed double vision at 60. After years of tests and appointments, she was diagnosed with CPEO. And looking back, she realized she had had symptoms for years.
That is a lot to carry. And then there is the emotional impact of getting the diagnosis. Did Emmy talk about that?
She did. The story describes her feeling shocked, numb, worried, sad, angry, and also hopeful. That mix makes sense. A diagnosis can be validating and frightening at the same time. It can give a name to what is happening, but it can also open new questions.
And sometimes people get more than one name. I have heard people say, I have CPEO, and also I have mitochondrial myopathy, and then something else again on a genetic report. How does that work?
That is such a good question. And the Mito Foundation has a resource that explains this clearly. It says Mito can be diagnosed and described in different categories: clinical, biochemical, and genetic. A clinical diagnosis is based on symptoms, health history, and a physical examination. A biochemical diagnosis is confirmed by non-genetic tests, often through a muscle biopsy. A genetic diagnosis uses genetic testing to confirm the specific type of mito by finding a genetic change.
So you might start with what is seen and felt, and then later learn what is happening at the genetic level?
Exactly. The resource explains that after a diagnosis, you may be given various names depending on what category of diagnosis you have received. Some people get a clinical diagnosis first, while more tests are done, and then later a biochemical or genetic diagnosis when results come in. And because mito can be classified by symptoms and by genetic change, some types can sit in more than one category.
That helps. It means multiple names are not necessarily a mistake. They are different layers of the same story.
Yes. The Understanding Your Diagnosis resource gives a specific example with CPEO. It introduces Sarah, who noticed droopy eyelids, double vision, and fatigue. She was referred to a neurologist, had a muscle biopsy that showed ragged red fibers, and was diagnosed with mitochondrial myopathy. After seeing a mito specialist, genetic testing confirmed CPEO caused by a mitochondrial DNA deletion. So Sarah had multiple names: mitochondrial myopathy, CPEO, and then a genetic diagnosis of mitochondrial DNA deletion.
I want to pause on ragged red fibers because people hear that and imagine something horrible. What is it in plain language?
On the CPEO page, it says a muscle biopsy may be needed, and that the biopsy looks for ragged red fibers under a microscope, which is a sign of some types of mito, like CPEO. So in plain language, it is a pattern seen in muscle tissue when it is examined closely. It is one of the clues that can support a diagnosis.
And the genetic testing part, that can feel like a big step. What does the CPEO page say about how genetic testing is done?
It says if your doctor suspects CPEO, they will arrange genetic testing to look for changes associated with the condition. Usually a blood or saliva sample is all that is required, but sometimes other samples like skin, hair, urine, or muscle are needed due to heteroplasmy, which we will explain in a moment. It also notes that genetic testing is highly specialized, and it may take up to 3 to 4 months to receive results, and that genetic counseling is important to discuss what the results mean for you and your family.
3 to 4 months can feel like forever when you are anxious, but it also makes sense if it is specialized. You mentioned heteroplasmy. That is one of those terms that sounds like a different language.
Let's translate it. Within your cells, both healthy and changed mitochondria can exist, and that this mix is called heteroplasmy. It uses an analogy of having good machinery and machinery that does not work as well. Sometimes the changed machinery does not cause immediate problems, but when the change affects a large portion of mitochondria, symptoms can appear.
So it is not a simple on-off switch. It is more like a percentage, and it can be different in different parts of the body.
Yes. In a family, different organs can be affected differently because of the uneven distribution of healthy and changed mitochondria. One person might struggle with energy supply, while another seems fine. It also notes that symptoms might skip a generation, which can happen when the mix of healthy and changed mitochondria stays below a threshold for symptoms in one person, but not in another.
That also explains why a blood test might not always show the genetic change clearly. If the mix in the blood is different from the mix in muscle, for example.
Exactly. That is why sometimes samples other than blood or saliva are needed. It is also why it emphasizes that genetic testing is important, but not all changes are easy to detect. So a thorough clinical evaluation is also essential.
Let's talk about causes, because people hear genetic condition and immediately jump to, did I inherit this? Did I pass it on? Is this my fault?
First, it is no one's fault. CPEO is a genetic condition caused by genetic changes that affect metabolism, which it defines as how the body converts food into energy and removes waste. It says this process relies on hormones and enzymes to run smoothly, and when a genetic change disrupts this process, it impacts mitochondrial function. Then it goes into where those genetic changes can be found, in mitochondrial or nuclear DNA.
Can you quickly explain mitochondrial and nuclear DNA without making it too sciencey?
Sure. Mitochondrial DNA is found in the mitochondria, whereas the nuclear DNA is found in the nucleus of the cell, the central compartment where most of our DNA is stored. The key point is that it can result from changes in either mitochondrial or nuclear DNA, and both types can affect how mitochondria function.
And the page gives some proportions, right? Like how often it is mitochondrial versus nuclear DNA.
It does. It says about 60% of people with CPEO have changes in mitochondrial DNA, often deletions in mitochondrial DNA. It says these changes are usually de novo, which it explains means new. A genetic change that occurs randomly during conception and is seen for the first time in a person, not in earlier generations. It also says there is usually no family history of mito in those cases, and that research suggests the risk of passing this genetic change onto future generations is low.
That word de novo matters. It gives people permission to stop searching their family tree for who to blame.
Yes. And the page also describes maternally inherited changes in mitochondrial DNA, meaning inherited from the mother. It gives one example of a mitochondrial DNA change that can cause CPEO and also causes MELAS. But the main idea is that some mitochondrial DNA changes are inherited maternally.
And what about when a mother carries a genetic change but does not have symptoms? That comes up in family planning conversations, and it can be emotionally complicated.
If the mother has no signs and symptoms of CPEO but carries the genetic change, she is known as a genetic carrier. It says all her children are at risk of inheriting the genetic change, but the severity can vary, and predicting who will develop symptoms and how severe they will be is challenging. It also says males with this mitochondrial DNA change cannot pass it on to their children.
That is a lot of weight to hold, and it makes genetic counseling sound essential, not optional.
I agree, genetic counseling is important to discuss what results mean for you and your family. It also highlights that the severity can vary and prediction is challenging, which is an important reality check.
And the nuclear DNA side, what do we know?
It says about 40% of cases are due to changes in nuclear DNA. It explains that changes in the nucleus can change how mitochondria work by disrupting the production of new mitochondrial DNA, interfering with the supply of essential building blocks, called nucleotides, or impacting how mitochondria function. It lists some nuclear genes that can be involved, and explains these genes are important for the creation and maintenance of mitochondrial DNA.
So nuclear DNA changes can still end up affecting mitochondrial DNA, like the copying and maintenance of it?
Yes, that is the way we describe it. It also notes that nuclear DNA changes can be transmitted in different inheritance patterns depending on the gene. The main takeaway for most listeners is there are different genetic pathways to CPEO, and that is why testing and genetic counseling are such a core part of care.
Let's go back to symptoms for a moment, because I want to make sure we cover the lived experience, not just the list. If someone has ophthalmoplegia and ptosis, what are the practical day-to-day impacts?
With ophthalmoplegia, as eye movement gets harder, people may need to turn their head to see in different directions. With ptosis, as eyelids droop more, you might use forehead muscles to lift the eyelids or lift your chin to see. Those are small movements, but they can become constant adjustments, and that can affect comfort, fatigue, and confidence.
And with swallowing difficulties, dysphagia, there is the worry about choking, and maybe eating becomes stressful.
Yes, it might feel like food is getting stuck, or you have choking episodes. If that is happening, it is one of those signs where talking to a health professional is important, because swallowing safety can be supported. And the page later lists a speech therapist as someone who can address and manage swallowing difficulties if present.
I notice how often the page comes back to the idea of a team, not just one specialist.
That is a key theme. In the monitoring section, it says if you have CPEO, you will likely need a team of health professionals to manage your care. It lists roles including your GP as the main point of contact, helping with referrals, tests, and coordinating care, as well as a neurologist to monitor progression, an ophthalmologist to monitor ptosis, ophthalmoplegia, and peripheral vision, and an orthoptist who works with an ophthalmologist to test vision with specialized diagnostic tests.
I have heard of ophthalmologists, but orthoptist is new to me, so they are part of eye care too.
Yes, orthoptists, as working with ophthalmologists to test vision and use specialized diagnostic tests to examine the visual system's function. It also lists a cardiologist to access and monitor heart conditions, a genetic counselor for education and support, a physiotherapist for mobility and strength, an occupational therapist for daily living, activities, and maintaining quality of life, and a mental health professional for well-being support.
That list is both reassuring and overwhelming. Reassuring because it means there are supports. Overwhelming because it sounds like so many appointments.
It can feel like that. And it is okay to feel both things at once. The point of naming the team is not to add pressure. It is to make it clear that Mito care is often shared across disciplines, and you do not have to carry it alone.
Let's talk about diagnosis tests in more detail because people might be at different points in that journey. What does the page say a diagnosis is based on?
It says a diagnosis is based on your history, signs and symptoms, physical examination, and other testing. It describes a physical exam, where your eyes and nervous system will be examined, your eye muscles checked, your ability to focus and move your eyes tested, and your ptosis measured.
And then it mentions other tests to rule out similar conditions, right?
Yes. It says blood tests may be used to rule out other conditions by checking for the lack of specific antibodies, including those for myasthenia gravis and thyroid-related eye problems. It also says an electrocardiogram, an ECG, checks heart rhythm, and an echocardiogram. An echo may be required to look for heart muscle issues, called cardiomyopathy.
That is a lot of acronyms.
It is. The page also mentions MRI, magnetic resonance imaging, described as a non-invasive imaging method that may be needed because it can detect signs of eye muscle shortening or weakness, called muscle atrophy. And it mentions a muscle biopsy, as we discussed, to look for ragged red fibers.
So the diagnosis is like building a picture from multiple pieces, not just one test.
Exactly. And that also explains why it can take time. It is also why someone like Emmy can have years of tests and appointments. It does not mean the person is imagining symptoms. It often means clinicians are trying to sort through possible causes and find the most accurate explanation.
Now, you promised a myth and fact moment, and I think I know what myth you're going for. Can we do it now?
Let's do it. Here is the myth. CPEO is only an eye condition. And here is the fact, according to the symptoms section. While the main features involve eye movement and eyelids, CPEO can be an isolated disorder or a multi-system disorder, and other signs and symptoms can include myopathy with exercise intolerance, dysphagia, hearing loss from inner ear nerve damage, neuropathy, ataxia, Parkinsonism, and depression. When additional signs and symptoms occur, it can be called CPEO+.
That matters so much because it changes how someone thinks about their body. It also might change what they tell their GP or specialist because they might have been keeping some symptoms separate in their mind.
Yes, and it can also reduce self-doubt. When symptoms seem unrelated, people can wonder if they are overthinking. Naming that CPEO can involve more than eyes can help someone bring their full picture to their health professional.
The page also mentions other conditions linked to CPEO, like mitochondrial myopathy and Kearns-Sayre syndrome. Can we touch on that without going too far off track?
It explains mitochondrial myopathy is a group of conditions that mainly affect muscles, causing weakness and fatigue, and that it often involves multiple body systems, such as the brain and eyes. It says if someone with mitochondrial myopathy begins to experience drooping eyelids or difficulty moving their eyes, their diagnosis may be updated to include CPEO. It also says it can sometimes be part of other conditions like CPEO plus or Kearns-Sayre syndrome, which include CPEO but have extra signs and symptoms not usually seen in people with CPEO.
So again, the theme is that labels can evolve as symptoms evolve, and that does not mean the original label was wrong. It means the picture is becoming clearer.
Exactly. And that can be frustrating, but it can also be progress. It can mean the care plan becomes more targeted to what the person actually needs.
Speaking of care plans, the page has a whole section on healthcare recommendations, especially eye care. What does it say there?
It says regular monitoring for Mito is important, and your health professional may recommend different tests to check how Mito is affecting you. Then, for eye care, it says if you have CPEO, it is essential to see an ophthalmologist for a thorough assessment. It lists what that can include: checking visual acuity, assessing visual fields, examining eye movements, and assessing drooping eyelids.
And it talks about low vision support too, doesn't it?
Yes. It says, if your vision is impaired, consider seeing a low vision specialist. It also says surgery may be an option for conditions like strabismus or ptosis, and it recommends annual visits with an ophthalmologist for ongoing monitoring, including checking for changes in vision, checking the health of the retina and macula, measuring intraocular pressure, and evaluating the health of the optic nerve.
That is very specific, which is helpful. But I want to be careful. This is not telling someone what they must do on their own. It is something to discuss with their eye specialist.
Absolutely. This is information to bring into a conversation with your health professional, not a substitute for medical advice. The page also includes a practical tip connected to comfort. It says if you find it difficult to close your eyelids due to ptosis or after ptosis surgery, consider using methylcellulose eye drops or ointments to keep your eyes lubricated and relieve dry, irritated eyes, and to ask your health professional which artificial tears are best for you.
Dry eyes can sound minor until you have them. It can be relentless. I'm glad it mentions that.
Small comfort measures can make a big difference to daily life, and it is good to know they are on the radar. Let's touch on brain and nerve care under neurology. It mentions pain and headaches, and says headaches and migraines are treated the same whether you have Mito or not, but that a sudden increase in migraine severity or new neurological symptoms may indicate a change in your health, and you should talk to your health professional about changes.
That is a good example of balanced messaging. It is not alarmist, but it says pay attention to changes.
Yes, and it also talks about myopathy management. It says to keep an eye on changes or worsening of myopathy symptoms. And if you notice anything different, talk to your neurologist or GP. It mentions they might do blood tests to check for high enzyme levels or other causes. Then it reinforces that when managing myopathy as part of Mito, it is essential to be proactive about your health and to discuss aspects with your health professional to get advice that fits your situation.
I like that phrase, advice that fits your situation, because Mito is so individual.
It is. And that individual variation is woven through the whole CPEO page. Even in the prevalence section, it says exact worldwide numbers are not known. And in the symptoms section, it says CPEO can present differently in different people.
The page also has a mental health section, which I really appreciate. It is easy for mental health to be treated like an afterthought.
It is, but taking care of your mental health is just as important as managing physical symptoms when dealing with CPEO. It says if you have psychiatric symptoms such as anxiety, depression, or memory loss, speak to your health professional. And it adds that for children, it is particularly important to watch for low self-esteem and anxiety, and addressing those feelings early can make a big difference to emotional well-being.
That is gentle and direct, and it connects to what Emmy said about feeling isolated as an adult managing Mito.
Yes. In Emmy's story on the CPEO page, it says she finds managing Mito as an adult isolating and wishes she had more specialist support. In her longer story, she describes being active in the Mito community, making connections through Facebook, preferring face-to-face events, and enjoying Mito Foundation meetups. It also includes her personal advice, which is not a medical prescription, but a lived perspective. She says, keep your brain busy and do what makes you feel alive.
I want to hold that carefully because for some people, staying busy is a lifeline, and for others, resting is survival. But it is still powerful to hear what helped her.
Exactly. We can take it as one person's story of meaning and connection, not a rule. And it can also remind us that emotional well-being is part of healthcare, not separate from it.
Now, can we talk about emergency care? Because that can feel frightening, but it is also practical.
The CPEO page has a clear section on emergency care. It says if your Mito specialist thinks you are at high risk of sudden illness, they should give you an emergency plan. It should include your diagnosis and clearly outline which tests and treatments are recommended for you. It also acknowledges it is hard to plan for emergencies, but there are ways you can help, like making sure you have current details of your main care team, including your GP, Mito specialist, and other health professionals who know you best.
That sounds like one of those small steps that actually reduces stress, because in an emergency, you do not want to be trying to remember names and numbers.
Exactly. The Australian Patient Care Standards for Mito and the important information about medicines can provide the treating team with extra information, which can help health professionals who may not be familiar with Mito.
That leads nicely into the medicine section, because people often wonder, are there medications I should avoid? And that can become a scary rabbit hole online.
The page handles this by focusing on caution and monitoring, and by repeatedly saying to speak with your health professional. It says certain medications can affect your muscles, listing statins for high cholesterol, metformin for blood sugar control, corticosteroids for inflammation like asthma, and antiretrovirals for viral infections such as HIV. It says they should be used with caution, and if you are prescribed any of these, regular monitoring is crucial to avoid worsening your myopathy.
So it is not saying never take these, it is saying use caution and monitor. So that is a big difference.
Yes. This is about supporting informed conversations, not making changes without medical guidance.
We have covered a lot of information. Can we switch into a practical what you can do next moment, but keep it grounded in what it actually suggests?
Let's do that and keep it concrete. If CPEO is part of your life, one next step supported by the emergency care section is to make sure you have up-to-date contact details for your main care team, including your GP and Mito specialist, and to ask your Mito specialist whether you should have an emergency plan and what it should include. Another next step supported by the healthcare section is to discuss with an ophthalmologist a thorough assessment of vision and eye movements, and ongoing monitoring, including annual visits if that fits your situation.
And if someone's vision's affected, they can ask about low vision support and consider seeing a low vision specialist if vision is impaired.
Yes. And if ptosis makes it hard to close the eyelids, or if someone has had ptosis surgery and is dealing with dry, irritated eyes, consider discussing lubricating options like methyl cellulose drops or ointments with a health professional, and asking which artificial tears are best for you. For muscle symptoms, another next step is to keep an eye on changes or worsening of myopathy. And if anything shifts, to talk to your neurologist or GP, as the neurology section suggests.
What about swallowing difficulties dysphagia? Because that can feel urgent.
The monitoring section includes speech therapists as part of the care team and describes them as addressing and managing swallowing difficulties if present. So a practical next step is to tell your health professional if you are having swallowing problems like food feeling stuck or choking episodes, and ask whether a speech therapist assessment is appropriate.
And the mental health part is also a next step, but people sometimes hesitate to name it.
Mental health is as important as physical symptoms. So if you are noticing anxiety, depression, or memory changes, another next step is to speak with your health professional about it. And for parents and carers, keeping an eye on a child's self-esteem and anxiety and addressing it early is also supported by the page.
The medicines to be used with caution section suggests a next step too. If you are prescribed any of the medications listed, to talk with your health professional about monitoring and to raise questions rather than quietly worrying.
Yes. Bringing it into the open is often the safest move. And there is another next step related to hope and research. The CPEO page says Mito Foundation supports people impacted by Mito to participate in clinical studies and can facilitate access to relevant studies, including clinical trials. It suggests joining the Mito registry to stay informed about opportunities that are relevant to you, and it points to a participate in clinical studies resource as well.
That is a hopeful point because it connects the individual to a bigger effort: prevention, diagnosis, treatments, and cures being worked on over time.
It is. The milestones section reminds us that knowledge grows. It notes CPEO was first described in the 19th century, and that later researchers discovered genetic changes associated with it, and that in recent decades, researchers have identified broader symptom patterns like facial weakness or swallowing difficulties. Research continues, with scientists working on better ways to manage symptoms and improve life for people living with CPEO.
Okay, now I want to ask something practical and emotional at the same time. If someone is sitting with a new CPEO diagnosis, what is a kind way to explain it to family or friends who have never heard of it?
You could say something like, CPEO is a rare genetic type of mito. In mito, mitochondria in the body do not make energy properly, and that can make it hard for parts of the body to work the way they should. With CPEO, the muscles around the eyes are often affected, which can cause droopy eyelids and trouble moving the eyes, and sometimes other parts of the body can be affected too. And then, importantly, you can add, my health team can help me monitor it, and the Mito Foundation has resources and support.
That last part matters because people often hear genetic condition and get stuck on the word genetic like it means unchangeable and hopeless.
And the CPEO information page doesn't present it that way. It presents it as a condition that can be understood, monitored, and supported. They also stress the importance of appropriate care and professional guidance.
We have talked about support in a general sense. What does the CPEO page say about support groups and community?
It lists the Mito Support Community Group on Facebook and it lists some international CPEO and Kern's SARE groups. The key takeaway is, even if there is not a dedicated local CPEO-only group, there are still community spaces to connect with others who understand Mito.
And what about Mito Foundation support services specifically?
The helpline is available, which is a place to call for general advice, assistance in seeking a referral, or more information on support services. It also mentions events that bring together people impacted by Mito and NDIS support through the NDIS navigation service, offering resources, education, and one-on-one guidance on the NDIS.
That is a lot of practical support. Sometimes people do not realize they can ask for help with referrals or navigating systems, not just information about Mito.
Exactly. Support is broader than symptoms. Emmy's story also shows that. She describes how meal preparation can take a lot of energy and how supports like cleaning help can make a real difference. She also describes the stress that can come when supports change and how that stress can affect health.
It is validating to hear that stress itself can have a physical impact, especially when your body is already managing limited energy. I want to circle back to the difference between CPEO and mitochondrial myopathy, because people might wonder, which one do I have when both words show up?
The way the Mito Foundation resources explain it, mitochondrial myopathy is a broader category describing mito that mainly affects muscles. CPEO is a syndrome described by particular symptoms, especially involving drooping eyelids and difficulty moving the eyes. The CPEO page says if someone with mitochondrial myopathy begins to have those eye symptoms, their diagnosis may be updated to include CPEO. And the Understanding Your Diagnosis resource explains that Mito can be classified by symptoms and by genetic change, so a person can have both a broader category name and a more specific syndrome name, plus a genetic diagnosis on top.
So if someone says, I have mitochondrial DNA deletion, that is a genetic diagnosis. And if they say I have CPEO, that is the syndrome name based on symptoms, and both can be true at once.
Exactly. And that is why the resource says Sarah has various names for her diagnosis. It is not confusion, it is layers.
Now, people impacted by Mito often become the translator in their family, at work, or even in medical settings. That can be exhausting.
It can. And it is why accessible resources matter. The CPEO page itself uses plain language explanations right alongside the medical terms. Ophthalmoplegia, explained as weak eye movement muscles. Ptosis, explained as drooping eyelids. Myopathy, explained as muscle weakness. Dysphagia, explained as difficulty swallowing. And heteroplasmy, explained as a mix of healthy and changed mitochondria.
That approach also helps someone advocate for themselves. Like if you can name dysphagia and also say it feels like food is getting stuck, a clinician can understand quickly.
Yes. And advocacy is not about being loud or confrontational. It is about being accurately heard. Diagnosis is based on history, signs and symptoms, physical exam, and other testing. Your story and your observations are part of the evidence.
I want to ask about progression, because CPEO is progressive and can worsen over time. That can feel scary. How do we talk about that in a way that does not spiral?
By staying grounded and specific. Progressive means change over time, but the pace and pattern can vary between people. Symptoms can be more severe when they start earlier, but it also shows through Emmy's story that onset and progression can look different for different people. The best practical response is not to predict the future, but to focus on monitoring, building a care team, and speaking up about changes, which are all actions supported by the information page.
That feels more manageable. It shifts from what will happen to what supports can I put in place.
Yes, and the emergency care section is a great example. It does not say expect emergencies. It says if your Mito specialist thinks you are at high risk, you should have an emergency plan, and you can help by keeping your care team details up to date and making sure treating teams have access to Mito care standards and important medicines information.
I want to bring us toward a close. Before we finish, can we summarize the key takeaways in a way that feels calm?
Yes, CPEO is a rare genetic type of Mito, often starting in early adulthood but possible at any age, and it is progressive over time. The main signs are weakness of eye movement muscles, ophthalmoplegia, and drooping eyelids, ptosis, and it can also involve other parts of the body, including muscle weakness, swallowing difficulty, hearing and nerve changes, coordination changes, and mood impacts, especially in CPEO+. Diagnosis is built from your story, examination, and tests, including genetic testing, and care often involves a team. Monitoring and support are available, including eye care, neurology care, mental health support, emergency planning where needed, and community and practical supports through the Mito Foundation.
That feels like a handrail, something to hold on to. And if someone is listening and thinking, this is me, what is the gentlest next action you would point them to based on the resources?
If you take only one action from today, let it be this. Bring your questions to your health professional and ask for care that fits your situation. And if you need help navigating referrals, services, or just having someone to talk things through with, the Mito Foundation helpline is there for general advice and assistance. And if you are building your support network, look at the Mito Foundation events and community supports. Because feeling connected can change everything about how manageable this journey feels.
You've been listening to MitoCast by Mito Foundation. To learn more or find support, visit mito.org.au or call our helpline on 1300977180. Make sure you follow MitoCast wherever you listen to this podcast to help us spread the word by sharing it with others impacted by Mito. Thanks for listening.